Now another important topic, in fact the most important topic, are sympatholytic drugs. These drugs will stop the activity of sympathetic system, and we have two main receptors in the sympathetic system, alpha receptor and beta receptors. So sympatholytics are broadly divided into alpha blockers and beta blockers. So sympatholytics may be alpha blocker, they may be beta blockers. We will discuss these one by one, starting from alpha blockers. Now we discussed earlier, alpha receptors are of two main types, alpha 1 and alpha 2. So alpha blockers may be of three types. One which block both of them. Second which block mainly alpha 1. And third which block mainly alpha 2. So alpha blockers are of three types. Now out of these three types, selective alpha 2 blockers have no clinical use. So just remember the name of the drug, which is Year Mbbs. It has no approved clinical indication, Year Mbbs. So we will not discuss this anymore. Effectively, we have two main alpha blockers. One is non-selective and second is selective alpha 1 blocker. So alpha 2 selective blockers we will not discuss further. Now coming to selective alpha 1 blockers and non-selective alpha blockers. Two important questions to answer. The first question, what is common between the two? Second question, what is different between the two? One by one, the common between the two. Both of them block alpha 1 receptors. And we know alpha 1 cause vasoconstriction. So if we block alpha 1, vasodilation will occur. And vasodilation will decrease blood pressure. So we can use any of these drugs for treatment of shock. For treatment of hypertension. Both of them will reduce the blood pressure. So both of them can be used for hypertension, non-selective as well as selective. Now coming to second thing, what is different between the two? The difference is that non-selective drug blocks alpha 2, but selective drug do not. And we discussed alpha 2 receptors may be presynaptic, which is the main thing, acting like a brake, may be postsynaptic. So we'll see what is the difference due to that. So noradrenaline is produced and stored here. When the nerve impulse comes, it is released. Then it acts on alpha 1 and beta 1 receptor here. Now, alpha 2 is mainly present here, presynaptic receptor. Small amount of little bit alpha 2 are present here, the function of which is like alpha 1. So when we give a non-selective drug, it will block alpha 1 as well as alpha 2. So when it blocks presynaptic alpha 2 receptor, that means it will stop the action of this alpha 2. Function of this alpha 2 was to press the brakes. When we block alpha 2 receptor, there will be failure of brakes. And when the brakes fail, that means more noradrenaline will be released. More noradrenaline is released. Now this noradrenaline, which is increased in the synapse, will try to stimulate both alpha 1 and beta 1. But the drug is non-selective, so it is blocking already alpha 1 receptor. But beta 1 is not blocked. So this noradrenaline will keep on acting on beta 1. And when it stimulates beta 1, that will result in tachycardia. So a non-selective alpha blocker can cause severe tachycardia by causing failure of brakes. So non-selective drug, it can cause severe tachycardia, which can even lead to palpitations by causing the failure of brakes. This is unlikely with selective alpha 1 blockers because brakes are not failed. On the other hand, when we block postsynaptic alpha 2, remember alpha 2 is also causing vasoconstriction. Action of this alpha 2 is similar to this alpha 1. So if a drug block both alpha 1 as well as alpha 2, it is a more strong vasodilator as compared to selective alpha 1 blocker. So non-selective drug is a more powerful vasodilator as compared to selective alpha 1. So non-selective alpha blocker, it can be used for severe hypertension, whereas selective alpha 1 blockers are used for mild to moderate hypertension only. So two important difference between a non-selective and selective alpha 1 blocker. A non-selective alpha blocker can result in severe tachycardia, but selective alpha 1 blocker do not cause. Second difference, a non-selective alpha blocker is used for severe hypertension, whereas selective alpha-1 blockers are used for mild to moderate hypertension only. So with this background, now we can discuss the drugs, starting with the non-selective alpha blockers. Non-selective alpha blockers, they may be irreversible or they may be reversible. Now, irreversible non-selective alpha blocking drug is phenoxybenzamine. Whereas reversible non-selective alpha blockers are phentolamine and tolazolone. Phentolamine and tolazolone are reversible. Phenoxybenzamine is irreversible. Now we already discussed that a non-selective alpha blocker is used for severe hypertension. And if a drug is irreversible, it will be long-acting. So in which condition there is severe hypertension and that too for prolonged periods? Yes, the answer is pheochromocytoma. So in pheochromocytoma, we can use phenoxybenzamine. On the other hand, phentolamine and tolazolone are also used for severe hypertension, but they are reversible, so they are short acting. So they are used for short term conditions to control severe hypertension, and these conditions are cheese reaction and clonidine withdrawal. We'll discuss these one by one, starting with cheese reaction. If you remember, we discussed earlier, cheese contains large quantities of tyramine. And tyramine is which type of drug? Yes, it is a sympathetic drug. So what does that mean? Whenever we are taking cheese, we are taking a sympathetic drug. Whenever we eat cheese, we should develop hypertension. But this does not happen. Now, why this does not happen? Because our GIT contains an enzyme called as monoamine oxidase. And this can break tyramine. So that means whenever we eat cheese, whatever tyramine is present in the cheese, it is metabolized by mouth. And when tyramine is broken, it cannot increase BP. So we can safely eat cheese without any problem of hypertension. The problem is, if we give a drug which is MAO inhibitor, we'll discuss later on, MAO inhibitors are used in depression. So if a person is having depression and person is taking MAO inhibitors and that person takes cheese, now what will happen? If a person is on MAO inhibitor therapy, cheese contains tyramine. Tyramine will not be broken because MAO is not working. So when it is not broken, it will be absorbed. And when it is absorbed, it acts like a sympathetic drug, and that will lead to severe hypertension, or that sudden hypertensive episode is known as cheese reaction. So the drug of choice for cheese reaction are phentolamine and tolazolone. Clear? Now second similar condition is clonidine withdrawal. Now what happens in clonidine withdrawal is, what is clonidine? Yeah, clonidine is alpha-2 agonist. That means it is pressing the brakes. So clonidine stimulate alpha-2 receptors, means press the brakes. When the brakes are pressed means noradrenaline will not be released. Noradrenaline do not come here. So when noradrenaline do not come here, then alpha-1, alpha-2 receptors, beta-1 receptors which are present here, they will not be stimulated. So when there is less stimulation of alpha-1 and beta-1 receptor, the BP decreases. We know that clonidine decreases BP. If a person is having BP of 160, clonidine may reduce the BP to 120. So as long as we keep on giving clonidine, BP remain low. Now suppose we stop some antihypertensive drug, what happens? When we stop antihypertensive drug, BP again become original, 160. But when we stop clonidine, after long-term use, this does not happen. If we give clonidine for 6 months, then we suddenly stop clonidine, BP will not return to 160, but rather the BP will become 220. Why? Reason is when we have given clonidine for long periods, it will keep on pressing the brakes. Noradrenaline do not come into the synapse. When noradrenaline do not come into the synapse for long periods, alpha 1 and beta 1 are not stimulated. And when they are not stimulated for long periods, their upregulation occurs. Their number increases. So now we have large number of alpha 1 and beta 1 receptors as compared to a normal person. But if noradrenaline do not come, they cannot do anything. Even if they are 10 times the normal, they will not do anything. But when we stop clonidine, now brakes are not pressed. Now noradrenaline will come. And when noradrenaline comes, it will find large number of alpha and beta receptors. Much more than the original value. So when large number of receptors are stimulated, the BP will become much more than original. So BP instead of 160 will become 220. This is known as rebound hypertension. Rebound hypertension. So clonidine, if we suddenly stop, the BP will shoot up, which is called as rebound hypertension. And as it is hypertensive emergency, severe hypertension, and again it is for short periods, so the treatment is phentolamine or tolazoline. Phentolamine or tolazoline, they are used for rebound hypertension or clonidine withdrawal. So that is important about the non-selective alpha blockers. Irreversible drug phenoxybenzamine is used in pheochromocytoma, and reversible drugs phentolamine and tolazoline, they are drug of choice for cheese reaction and clonidine withdrawal. Now moving to second group of alpha blockers. These are selective alpha 1 blockers. 2 points we already covered. 1, they do not cause severe tachycardia, palpitations. Second, they are used mainly for mild to moderate hypertension. The drugs in this category are which end with josin. Examples like prazosin, tirazosin, doxazosin, and L-fujosin. The drugs whose name end with the josin are selective alpha 1 blockers. So these are used for mild to moderate hypertension. Now do you remember, apart from blood vessels where else alpha 1 is present? Yes, alpha 1 is present in the prostatic urethra also. And what is the effect of alpha 1 on prostatic urethra? It decreases urine outflow. So if we block alpha 1, urine outflow increases. So we can treat a disease called BHP. So alpha 1 blockers can be used for treatment of BHP also. In BHP, if we see, this is the bladder, this is urethra, and around the urethra we have prostate hair. Now when the prostate grows, it not only grows outside, but it also grows inside. So in BHP what happens is, prostate grows both outside as well as inside. So when the prostate grows inside, it will cause obstruction of the urethral lumen. And when urethral lumen is obstructed, it decreases the urine outflow, urinary retention can occur. And this is complicated by the fact that this urethral lumen, they contain alpha 1 receptors, particularly alpha 1A type of receptors. So when the prostate grows, these get irritated. So when they get stimulated due to irritation, alpha 1 receptor stimulation result in contraction of urethra. So that means little bit of lumen which is patent, even that gets contracted, that gets blocked. So the urinary retention occurs. So if we want to treat the urinary retention, we want to improve the symptoms of PHP, the obvious thing we will want to do is block alpha 1 receptors. And the drug blocking alpha 1 receptor is called tamsulosin. So this drug, it stops the dynamic component. That means urethra is not always contracting. So whenever the urethra contracts, it will relax that urethra. So this is known as a dynamic component. Dynamic component means which is present sometime, not present sometime. But remember, tamsulosin do not affect the size of prostate. The prostate is large, it remains large. So this enlarged prostate, this component is called as a static component. So alpha blockers like tamsulosin, they only relax the urethra, means they affect the dynamic component and improve the symptoms. They only improve the symptoms, they do not stop the growth of prostate. On the other hand, the prostate grows because of testosterone. Remember, there is a hormone called testosterone. It is converted to dihydrotestosterone, which cause growth of prostate. And the conversion of testosterone to DHT is done by an enzyme called as 5-alpha reductase. So 5-alpha reductase convert testosterone to dihydrotestosterone. Dihydrotestosterone causes stimulation of prostate growth. Prostate grows in response to DHT. So if we want to decrease the growth of prostate, decrease the size of prostate, then we need to block 5-alpha reductase. So 5-alpha reductase inhibitors like finasteride, they decrease the size of prostate. That means they affect the static component. So if we see in BHP, there are two components. One is a dynamic component, means the contraction of urethra, and second is static component, means growth of prostate. The dynamic component is benefited by tamsulosin like drugs, alpha blockers, whereas static component means growth of prostate, that is benefited by finasteride. It inhibits the growth of prostate. Clear? So actually we usually start both the drugs together, finasteride plus tamsulosin. Tamsulosin will immediately provide the symptomatic relief, and finasteride will decrease the size of prostate, but that will take long time, around months, 4, 5, 6 months will be taken. Clear? So that is about the static and dynamic component in BHP. So alpha-1 blockers are used in hypertension. Alpha-1 blockers are used in BHP also. If a person has both of them, then a single drug will treat both. So that's why alpha blockers like prazosin, they are drug of choice in a patient having both hypertension and BHP. Person with hypertension plus BHP, drug of choice are Josins. Remember, both of them are likely to coexist because BHP is mainly a disease of elderly male, and elderly male is likely to have hypertension also. So if both of them are present, then the drug of choice is Josin. Now important problem. The major problem with these drugs is first dose hypotension. First dose hypotension. The other name is postural hypotension. So alpha blockers, they can cause postural hypotension, and it is called first dose hypotension because this side effect is seen only with first few doses. So after that, the tolerance will occur to this side effect. So as long as person is lying or sitting, there is no problem. But if the person suddenly stands, the BP will fall. So postural, depending upon the posture, BP falls. Normally postural hypotension is not a big problem, but because of the age group, it becomes very dangerous. So elderly male, 80-year-old male, if take prazosin, stands up and BP falls, the person will fall. And if a person falls, there will be fractures and it will be very difficult to heal now. So we want to prevent this side effect at all costs. How to prevent this is very simple. So alpha blockers are always given at bedtime. Alpha blockers are always started at bedtime, so that person take the drug and sleep. If the person do not stand, BP will not. Now if a person is having hypertension with BHP, we have to decrease the blood pressure. So that means we have to tolerate this side effect, because when the BP decrease, this will also, more decrease will also. But on the other hand, if a person is having only BHP, blood pressure is normal, then this is a totally unwanted side effect. So in this person, we want that only the effect should come on prostate, not on blood vessels. So we did the further research and we found that alpha-1 receptors are also of two types, alpha-1A and alpha-1B. And you can easily remember B for blood vessels. So alpha-1 subtype which is present on the blood vessels is alpha-1B, whereas alpha-1 which is present on the prostatic urethra are alpha-1A. And the drugs we are discussing so far, like prazosin, terazosin like drugs, they are blocking both alpha-1A and alpha-1B. By blocking alpha-1A, they will increase the urine outflow, so they are used in BHP. By blocking alpha-1B, they are causing vasodilation, so they are useful in hypertension. But by blocking alpha-1B, they are also causing postural hypotension. So if a person is having only BHP and the blood pressure is normal, then we do not want any effect on alpha 1b. So we will like to give selective alpha 1a blocker, and we have developed such drugs now, and the selective alpha 1a blocking drugs are tamsulosin, and a new drug recently approved is silodosin. So tamsulosin and silodosin, these are selective alpha 1a blocker. The advantage of these drugs over prazosin is they do not cause postural hypotension. They have negligible chance of causing postural hypotension.
We discussed that tamsulosin is selective alpha 1a blocker. So the advantage of that is it do not block alpha 1b, so it will not cause vasodilation. So that means it will not cause postural hypotension. Whereas the drugs which end with josin, like prazosin, terazosin like drugs, they block both alpha 1a as well as alpha 1b. Alpha 1a blockade can be used in BPH, but problem is by blocking alpha 1b they cause vasodilation, which is responsible for postural hypotension or first dose hypotension. But we can utilize this postural hypotension, not postural hypotension, vasodilatory action for treatment of other conditions also. So alpha 1b blocker, that means prazosin like drug, josin group of drugs, they have other indications also apart from BPH. Tamsulosin is only used for BPH. Prazosin can be used for other conditions also. And what are those conditions? They are causing vasodilation, so they can be used in hypertension. Prazosin like drugs can be used in hypertension, and the special point about prazosin like drugs in hypertension is they have beneficial effect on lipid profile. Most of the antihypertensive drugs like thiazides or beta blockers, they worsen the lipid profile, whereas alpha blockers, they benefit the lipid profile. They correct the dyslipidemia, right? So they can be used in hypertension. Second, they can be used in peripheral vascular disease like Raynaud disease. So what happens is the patient of peripheral vascular disease or Raynaud disease, they are sensitive to vasoconstriction. Like a normal person develop vasoconstriction in winters. So when there is extreme winter, to prevent the loss of body heat, the vasoconstriction occurs. So winter induces vasoconstriction, cold induces vasoconstriction, so that vasodilation do not occur. When the blood do not come, the heat will not be lost. This is a protective phenomenon. But problem is patient with peripheral vascular disease like Raynaud disease, they are extremely sensitive to vasoconstriction. So whenever the cold occurs, whenever the winter comes, these people will develop so severe vasoconstriction that ischemia occur. So periphery, they become pale, and that leads to pain. So in patients with peripheral vascular disease, we will like to cause vasodilation. So that vasodilation will prevent these symptoms. So alpha blocker can be used in peripheral vascular disease. Prazosin like drugs will be useful. Tamsulosin will not be effective. Scorpion sting. So when the scorpion bites, the venom of the scorpion sting is a powerful alpha 1 agonist. So it goes to different places, stimulate alpha 1, cause widespread vasoconstriction. So the person may develop pulmonary edema and many problems. Okay? So all of these can be reversed by alpha blockers. So in fact, prazosin like drugs, they are a drug of choice for scorpion sting. Prazosin like drugs are drug of choice for scorpion sting. Okay? So basically, non-selective alpha blockers, non-selective alpha 1 blockers, that means alpha 1a plus alpha 1b blocker, that means josin group of drugs, they have other uses also apart from benign hyperplasia of prostate, whereas tamsulosin has only one use, that is BHP. Clear?
So that is all about the alpha blockers. Now we'll move to our last topic in the autonomic nervous system, and that is the most important topic, which is beta blockers. We discussed we have two main type of beta receptors, beta 1 and beta 2. So just like alpha blockers, beta blockers may be of three types. one which block both of them, second which block mainly beta 1, and third which block mainly beta 2. So non-selective beta blocker, selective beta 1 blocker, selective beta 2 blocker. Now out of these, selective beta 2 blocker has no clinical use, just like selective alpha 2 blocker, and the name of the drug is butoxamine. Butoxamine, it is selective beta 2 blocker. It has no clinical use. So we will not discuss this drug anymore. So effectively, we have two type of beta blockers, one non-selective and second selective beta 1 blocker. So same two question comes. First, what is common between the two? Second, what is the difference between the two? The common in two is both block beta 1. When both block beta 1, they will affect the heart. Both of them are used for cardiac indication. Remember, in the heart we have mainly beta 1. The difference between the two is this drug block beta 2, this do not block beta 2. So that means when we want to block beta 2, we have to use this drug, non-selective. When we do not want to block beta 2, we will prefer selective beta 1 block. Now what are the conditions where we want to block beta 2 and what are the conditions where we do not want to block beta 2? Remember, in the heart we have beta 1, everywhere else we have beta 2. So that means any use of beta blocker which is outside the heart, we have to use a non-selective beta blocker. So non-selective beta blocker have more indications. They have cardiac indications as well as non-cardiac indications. On the other hand, selective beta 1 blockers have only cardiac uses. Second thing, if we do not want to block beta 2, we cannot use a non-selective drug. We can use only beta 1 selective drug. And what are the conditions where we do not want to block beta 2? For that we need to revise where beta 2 is present. Remember, we discussed beta 2 is present in the bronchus. Beta 2 is present in the blood vessels. Beta 2 is present in the liver. In the bronchus, effect of beta 2 is to cause bronchodilation. So when we give a beta 2 blocker, it will cause bronchoconstriction, and bronchoconstriction will worsen asthmatic patients. So we do not want to block beta 2 in a patient with bronchial asthma. Second, beta 2 in the blood vessels cause vasodilation. Beta blockers will cause vasoconstriction, and vasoconstriction will worsen the condition of patients with peripheral vascular disease like Raynaud disease. They already have vasoconstrictive property, and if we block beta 2, more vasoconstriction will occur. So Raynaud disease patients or peripheral vascular disease patients, we will not like to block beta 2. Now in the liver we discussed beta 2 result in reversal of hypoglycemia. So if we block beta 2, hypoglycemia cannot be reversed. So person can go into coma. And which person has risk of developing hypoglycemia? Yes, diabetic patient. So we will not like to block beta 2 in diabetic patients. So these three patients, asthma, peripheral vascular disease and diabetes, we will not like to block beta 2. Usually we will like to avoid any beta blocker in these patients. But if it is must to give a beta blocker, we will prefer the selective beta 1 blocker. A non-selective beta blocker is contraindicated in asthmatics, peripheral vascular disease patients and diabetic patients. So we discussed non-selective as well as selective beta 1 blockers. They can be used for cardiac disease. Non-selective beta blocker can be used for non-cardiac disease also. But non-selective beta blockers are contraindicated in asthma, diabetes and peripheral vascular disease. Now one more thing to remember, a non-selective beta blocker is called as first generation beta blocker. Selective beta 1 blockers were developed later, so they are relatively new drugs and also called as second generation beta blockers. So non-selective beta blockers are first generation and beta 1 selective are second generation. So now we can discuss the name of the drugs. So we'll discuss the names of beta 1 selective blockers, or we can say cardioselective beta blockers. They are also known as second generation beta blockers. The name of these beta blockers you can remember easily from the mnemonic. New beta blockers act exclusively at myocardium. New beta blockers act exclusively at myocardium. So the sentence itself tells that, first of all, these are new beta blockers, means they are second generation. Second thing, they act exclusively at myocardium. That means they will act only at heart. That means they have only cardiac uses. They cannot be used for non-cardiac indications. And further, they are acting only at heart. That means they will not cause side effect outside the heart also. So they are relatively safe in asthma, diabetes and peripheral vascular disease. And the drugs are NE, it stands for Nebivolol. Nebivolol. Remember, all beta blockers end with LOL, which is very famous these days because of Facebook. Then beta stands for bitoxolol. Another B stands for bisoprolol. AC stands for acebutolol. E stands for esmolol. AT stands for atenolol. M stands for metoprolol. And C stands for celiprolol. Remember, in total we have more than 40 beta blocker now. Out of them, only 8 are cardioselective, which we can remember as new beta blockers act exclusively at myocardium. So only 8 are cardioselective. Rest all beta blockers, that means rest all the drugs ending with LOL are non-selective beta blockers. And the advantage of cardioselective beta blockers is they are relatively safe in asthma, diabetes and peripheral vascular disease. This is the most important property of beta blockers, which is cardioselectivity. Now we'll discuss the another important property of beta blockers, which is called intrinsic sympathomimetic activity. Intrinsic sympathomimetic activity. First of all, we'll try to understand what is the meaning of this term. If you see, the term says sympathomimetic. That means it will stimulate the sympathetic receptors. But which drugs we are talking about? We are talking about beta blockers. That means drug which is blocking the sympathetic receptor. So how it is possible that a drug can stimulate same receptor as well as drug can block same receptor? That means the drug is neither able to stimulate the receptor completely nor able to block the receptor completely. And which drug has such property? Yes, partial agonist. Intrinsic sympathomimetic activity simply means the drug is partial agonist at beta receptors. Drug is partial agonist at beta receptor. So first of all, we'll try to understand the clinical importance. For that, we'll take an example. Suppose we have 10 beta receptors in heart. Beta receptors suppose are present in heart, and whenever one beta receptor is stimulated to maximum potential, suppose heart rate generated will be 10. Maximum heart rate we can generate is 10. Normally in the body we have catecholamines like adrenaline, noradrenaline and dopamine. They are agonist on beta 1 receptors. So normally they will bind to all the 10 receptors. If one receptor is producing a heart rate of 10, so 10 receptor will produce a heart rate of 100. So this person is having a normal heart rate of 100. This person develops some cardiac disease or any disease for which we want to give beta blocker. Beta blocker means antagonist. Normally, whenever we give beta blocker to a person, it binds to 10 to 20% of the receptors. So we assume out of the 10 it binds to 2 receptors. And what is the effect of antagonist? How much action? 0. So on these 2 receptors it will produce 0 action. But rest of the 8 receptors are free. So adrenaline can now bind to 8 receptors and it will produce a heart rate of 80. So that means on giving a beta blocker, heart rate decreases. From 100 it becomes 80. But this decrease in heart rate is minor. It is not of any clinical problem because slight decrease in heart rate does not matter. So normally we can give beta blocker without any problem. The problem is some people are sensitive to beta blockers. Sensitive to beta blocker means it can bind to 70 to 80% of the receptors. In a normal person it binds to 10 to 20% of the receptor. In some people beta blocker bind to 70 to 80% of the receptor. Suppose we give beta blocker to such a person, it binds to 8 receptors out of 10. So on all 8 it will produce heart rate of 0. Only 2 receptors are available for catecholamines to bind. So the heart rate of this person will suddenly drop to 20. So from 100 heart rate will suddenly drop to 20. This is a severe bradycardia and the person may die because of this. So we should not give beta blocker to such a person. But the problem is how we will come to know which person is sensitive, which person is not. No method to know. So the only thing we can do is we can give beta blocker and then come to know. So it is very important whenever we give beta blocker, we should monitor the heart rate. Particularly when we use injectable beta blockers, heart rate must be monitored. If the heart rate decreases slightly, it is a normal phenomenon. But if the heart rate decreases drastically, means that person is sensitive to beta blocker. So stop giving beta blocker immediately and use some other drug. But suppose beta blocker is the only treatment. No other treatment is available. So we want to treat the patient also, but we cannot afford severe bradycardia. So what is the solution? So now the solution lies in partial agonist. Remember, partial agonist will not produce 0. Partial agonist will not produce 10. It will produce in between. Suppose we assume partial agonist produce half the action, 5. So partial agonist will bind to these 8 receptors. On all these 8 receptors, it will produce heart rate of 5. So 8 into 5, it produces heart rate of 40. And 2 into 10, 20 is produced from adrenaline. So this person, after giving partial agonist, the heart rate will drop to 60, not 20. So this person will not develop that severe bradycardia and the person will not die. So that is the importance of intrinsic sympathomimetic activity or partial agonistic activity. That means this drug has less risk of causing severe bradycardia as compared to antagonist. But important thing, because it is a partial agonist, obviously it is likely to be less efficacious. In a normal person, it will not be that much efficacious. But if a person is developing severe bradycardia, then it is a safer drug. So now the name of the drugs. Name of the drugs you can remember as contain partial agonist activity. Contain partial agonist activity. So C for celiprolol, P for pindolol, A for alprenolol, AC for acebutolol. So these are the important drugs with partial agonistic activity. So disadvantage is they are less effective, but the advantage is they cause less bradycardia as compared to complete antagonist. Now moving to third important property of beta blockers. It is called membrane stabilizing property. Membrane stabilizing property. Now before going to this property, we need to understand which ion channel normally cause depolarization. Yes, it is sodium channel. So if a drug blocks sodium channels, depolarization will not occur. That means membrane will become stable. So basically any beta blocker which can block sodium channels is said to have membrane stabilizing property. And we also know if we block sodium channel in the neurons, it will lead to local anesthetic property. So all these three terms have same meaning: membrane stabilizing property, or sodium channel blocking property, or local anesthetic property. Now coming to clinical importance of these. First and very simple question: in which disease of heart you will want that membrane should become stable? Yes, it is arrhythmias. So these beta blockers are preferred in arrhythmias because they will stabilize the membrane of the heart, so arrhythmias can be treated. Now second important thing is they have local anesthetic property, and this property, it is very undesirable in a patient with glaucoma. The question is why? Now to understand that, we'll take a very simple example. This is our eye. It contains cornea. Now what is the blood supply of cornea? Very good. Cornea is avascular. It do not contain any blood supply. The question is why we require blood supply? Blood supply is required for two main functions. One, it provides the nutrition. Second, it result in healing. If any injury occur, it will bring the chemicals so the healing can occur. So how the cornea get the nutrition? So it can get the nutrition from the aqueous. How it heals? So that is the problem, cornea do not heal. That means if any injury occur to cornea, it cannot heal because there is no blood supply. So when it is not able to heal, the only protective method is it should not get injured. So we want that cornea do not get any injury, and to protect it from injury, cornea is supplied with large number of sensory nerves. Large number of sensory nerves, which are branches of trigeminal nerve, they are supplied to cornea. So it is so much sensitive that even if a very small dust particle touch the cornea, immediately the eye can sense, because these nerves will be stimulated, and these will pass the information to the facial nerve, which will contract the orbicularis oculi, or in simple language, if anything touch the cornea, eye closes. So that's why damage do not occur to cornea. It is a protective reflex which is called as corneal reflex. Corneal reflex. So corneal reflex means if anything touch the cornea, eye closes. It is a protective reflex. So the pathway is when anything touch the cornea, sensory nerves are stimulated. They give the information to facial nerve that will stimulate the orbicularis oculi, that will close the eye. Now if we inject any local anesthetic in the eye, any beta blocker which has local anesthetic property, if we give in the eye, so these sensory nerves cannot sense because we have anesthetized these nerves. Now if some dust particle or mosquito enter the eye, corneal reflex will not occur because there is no sensation, and if the eye do not close, there is chance of damage to the cornea, and if the damage occur to the cornea, that will be permanent. So the person may develop permanent blindness. So we will not like to take that risk. So any drug which have local anesthetic effect should not be used for long term in the eye. Although beta blockers have good effect on glaucoma, they can decrease the intraocular pressure, but if a drug is having local anesthetic property, it can harm by causing anesthesia of the cornea. So we will not like to use beta blockers in treatment of glaucoma if they have local anesthetic property. Clear? So now the name of the drugs. These you can remember as possess membrane stabilizing or local anesthetic property. Possess membrane stabilizing or local anesthetic property. Again, the sentence tells everything. They possess membrane stabilizing property, means preferred in arrhythmias. They have local anesthetic property, so they are avoided in glaucoma. The drugs are P for propranolol, which has maximum membrane stabilizing property. ME for metoprolol. L for labetalol. A for acebutolol. And P for pindolol. These are the beta blockers having membrane stabilizing property. They can be used in arrhythmias, but they are avoided in glaucoma.
The fourth property of beta blockers is water solubility. Now, if a drug is water soluble, means it cannot cross the membranes. So these beta blockers do not enter the brain, so they have a negligible CNS side effects. CNS side effects are not there. They are not able to cross the blood-brain barrier. So the side effects of beta blockers in brain, like nightmares, delirium, they are absent in these beta blockers. But these beta blockers are contraindicated in renal failure. Remember, which drug is filtered by the glomerulus? Both lipid soluble as water soluble. But which drugs comes back? Lipid soluble. So that means if a beta blocker is water soluble, it can be filtered, but it will not come back. That means it is entirely the responsibility of kidney to remove this beta blocker. So if kidney fails, then this beta blocker cannot go out of the body. So that can result in toxicity. So these beta blockers are contraindicated in renal failure. Clear? So two important properties: contraindicated in renal failure, but they do not produce CNS side effects. Okay? And which beta blockers are water soluble? These are remembered as ANS. ANS. So ANS is contraindicated in renal failure. The drugs are A for atenolol, S for nadolol, S for sotalol. So atenolol, nadolol and sotalol, they are contraindicated in renal failure, but they do not cause CNS side effects. And one more thing you can remember, nadolol is the longest acting beta blocker. Longest acting beta blocker is nadolol. And you can remember in Hindi, नाड़ा लंबा होता है तो नाडोलोल longest acting है. नाड़ा लंबा होता है, नाडोलोल longest acting है. So which beta blocker is shortest acting? Esmolol is shortest acting beta blocker, and you can remember from the name itself, its name says E for extremely, S for short acting. So extremely short acting beta blocker is esmolol. And how short acting it is? Yes, its action remain for less than 5 minutes. Do you remember which other drug we discussed whose action remain for less than 5 minutes? Yes, succinylcholine. And do you remember why succinylcholine was so short acting? Because it was metabolized by pseudocholine esterase. And same happens to esmolol also. Esmolol is also metabolized by pseudocholine esterase. That's why it is very short acting. Clear? So this is about number 4 property, water solubility. The next important property of beta blockers is third generation beta blockers. So here we will discuss about third generation beta blockers. Third generation beta blocker is any beta blocker. It may be first generation, that means this cardioselective, or it may be second generation, that means non-selective. So that means any beta blocker which cause vasodilation is called third generation beta blocker. Now question is, which beta receptor is present on the blood vessels? So it is beta 2, and when we stimulate beta 2, what happens? Vasodilation. So then how come a beta blocker will cause vasodilation? Beta blocker should cause vasoconstriction. So that means the vasodilation which is produced by beta blocker is not due to beta blockade. It is due to some extra property. So due to any extra property, if a drug causes vasodilation, it will be called third generation beta blocker. So what are those extra properties? The first important property that can be seen is if a drug block alpha receptors. So alpha plus beta blocker can be called as third generation beta blocker. And the drugs which are alpha plus beta blockers, they are labetalol and carvedilol. Labetalol and carvedilol, they are third generation beta blockers. They block alpha 1 receptors, and you can remember we have two main receptors of sympathetic system, alpha and beta. So these drugs have blocked both alpha as well as beta. मतलब इन्होंने सिंपैथेटिक सिस्टम की पूरी दुकान बंद कर दी और अब ये घूमने जा रहे हैं, इसलिए हमने इनका नाम रख दिया ला बेटा कारलेया. ठीक, हम घूमने जाएंगे. तो ला बेटालोल एंड कार्वेडिलॉल, दे आर अल्फा प्लस बीटा ब्लॉकर्स. Then second mechanism of causing vasodilation The drug may block beta receptors, but in addition, the drug releases nitric oxide. You know, nitric oxide is a powerful vasodilation. So if a drug release NO, it can cause vasodilation. And the beta blockers which release NO, these include nebivolol and nipradilol. Nebivolol and nipradilol, these act by releasing nitric oxide. Okay. Then third mechanism by which we can cause vasodilation, the drug which block beta receptors and in addition is a calcium channel blocker. You know, calcium cause vasoconstriction. If we block calcium channel, vasodilation will occur, and such drug include carvedilol. Carvedilol. Remember carvedilol we discussed earlier also. Yes, it is alpha blocker also and it is calcium channel blocker also. And again from the name you can remember its name contains car. Remember la beta car le. So alpha plus beta blocker plus its name start with the Ca means it is calcium blocker also. Calcium blocker also. Okay? And one more property of carvedilol, it is antioxidant also. So carvedilol, you need to remember the important properties. It is a beta blocker, it is an alpha blocker, it is a calcium channel blocker, and it contains antioxidant property also. Okay? Then another way of causing vasodilation is if a drug block beta receptor but open potassium channels. Remember, potassium channel cause vasodilation, and this drug is tilsolol. Beta blocker plus potassium channel opener. Okay. And one last mechanism by which a drug can cause vasodilation is if a drug block beta 1 receptors but stimulate beta 2 receptors. So it is a beta blocker which can cause vasodilation, and this beta blocker is celiprolol. Celiprolol is beta 1 blocker and beta 2 agonist. And one special point to remember, we know beta blockers cause a dyslipidemia. They decrease HDL, increase LDL, etc. And that is mainly because of blocking beta 2. So if a drug stimulate beta 2, not block beta 2, then it should improve the lipid profile. So it has been found that celiprolol increase HDL instead of decreasing, unlike other beta blockers. Clear? So that is about the third generation beta blockers. Clear?
So these are the 5 important properties of beta blockers. Now we'll move to the last thing in beta blockers, that is the uses of beta blockers and adverse effects of beta blockers. So starting with the indications or uses of beta blockers. So beta blockers, we can use them because they are blocking beta 1, or we can use them because they are blocking beta 2. We know beta 1 is mainly present in heart. So we can use beta blockers for cardiac indications. And they are very easy to remember. Just open the textbook of any of your medicine or pharmacology book. Open the index, see the cardiovascular system, and now see the chapters. Whatever chapter name is there, we can use beta blocker. Like there is a chapter called hypertension. So beta blockers can be used in hypertension. There is a chapter called angina. Beta blockers can be used in angina pectoris. Beta blockers can be used in myocardial infarction. Beta blockers can be used in congestive heart failure. Beta blockers can be used in arrhythmias. So that means we can use beta blockers in almost all cardiovascular conditions. Only important thing is they may not be useful in some subset of those conditions or may even be harmful. Like angina is of 2 types, classical angina and variant angina. Beta blockers are used in classical angina, but they are contraindicated in variant angina. Similarly, CHF may be acute CHF or chronic CHF. Beta blockers are used in chronic CHF but contraindicated in acute CHF. So subsets we may not use, but in general we can use in all cardiovascular conditions. Now we can use beta blocker due to beta 2 blockade. So basically non-cardiac uses outside the heart. So outside the heart we can use beta blockers in glaucoma, anxiety, migraine, essential tremors, thyrotoxicosis. So important uses of beta blockers outside the heart. They can be used for glaucoma, anxiety, migraine, essential tremors, and thyrotoxicosis. So if you remember again, non-selective beta blockers can be used for all of these indications, whereas second generation or cardioselective beta blockers are used only for beta 1 blocking indication. That means only cardiovascular indication. Clear? So these are the uses of beta blockers. Now coming to adverse effects or contraindications of beta blockers. Adverse effects or contraindication. Again, we can divide this into problems due to beta 1 blockade and problem due to beta 2 blockade. Beta 1 we know is present mainly in heart. So beta blockers will depress the heart. So they can depress three things in the heart. One, they can decrease heart rate. Second, they can decrease conduction. Third, they can decrease contractility. So beta blockers decrease heart rate. So they are contraindicated if a person is already having decreased heart. So they are avoided in a patient with bradycardia. They are also contraindicated if a person is having a disease called sick sinus syndrome, which is characterized by severe bradycardia. So they decrease the heart rate. So they will be contraindicated when heart rate is already less. Second, beta blockers decrease conduction. So they will be contraindicated when there is already conduction block. So that means they are contraindicated in patients with AV block. They can decrease contractility. So they are contraindicated if already contractility is less, and which is the case in patient with acute CHF. So beta blockers are contraindicated in bradycardia, sick sinus syndrome, AV block, and acute CHF. Now we discussed beta 2. Beta 2 we will not like to block in three conditions, that is asthma, peripheral vascular disease, and diabetes. So beta blockers are contraindicated, particularly non-selective, in asthma, diabetes, and peripheral vascular disease. So among these, the important ones you can remember, which you must remember, are A, B, C, D. Beta blockers are contraindicated in A, B, C, D. A for asthma, B for block, block means AV block, C for CHF, CHF means acute CHF, and D for diabetes. So beta blockers are contraindicated in asthma, AV block, acute CHF, and diabetes mellitus. So these are the important points regarding the beta blockers also. That means we have completed the topic of autonomic nervous system.